So my name is Bob Bell, and I'm the President and Chief Executive Officer of University Health Network. And the question you've asked me to describe is whether or not physicians should be paid on a fee-for-service basis or potentially on a salary basis, especially doctors that work with hospitals. And, you know, to reflect on that for a moment, let's talk about the quality of health care provided, and is there any evidence that we've got from other systems as to whether there's a difference in quality as to whether or not physicians are paid one way or another. If we think of our North American neighbors south of the border in the United States, it's interesting that there's one defining feature of the hospitals and hospital systems that are thought to be the best performing and the highest quality in the United States. Whether we talk about interurban health care, whether we talk about the Mayo Clinic, the Cleveland Clinic, the VA health system, Veterans Administration health system, one defining feature of those organizations that have certainly been referred to by Americans, by the American president, as being some of the highest performing health systems, the highest quality health systems. Physicians work for the employer, the hospital, or the health system in each one of those cases. So that's interesting to me, that in the United States, quality seems to equal employed physicians. Certainly in the hospital system and the healthcare system that's referred to as the most effective and highest quality, the Kaiser Permanente health system, physicians are clearly employees. However, the difference between most of those systems and what we have here in Canada is physicians also own the system in most of those cases. So when you look at the Mayo Clinic, it's a not-for-profit that's owned by the people that work there, essentially, similarly to the Cleveland Clinic. These are, at some level, physicians owning the organization that's paying them a salary, and certainly if their performance warrants it, if the results of the organization warrant it, they will receive variable compensation related to the organization's results. So I think it's hard to say that physician being paid by system in the United States equals higher quality system without also recognizing the fact that physicians have an ownership opportunity, an equity interest in the organization they're working with. So I think that's one issue. I don't think there's any question here in Canada we are losing an opportunity to increase the sustainability of our system by ignoring some of the opportunities for scope of practice enhancement within our system. We have a fund of dollars in Ontario that's not fungible in terms of the provision of care. These are doctor dollars. They're dollars that are governed by the OMA Physician Service Agreement with the government. And if we can demonstrate potentially that services within those bracket of funded dollars could be provided by a different provider, if a routine check of a patient's blood pressure could be done more effectively by a nurse and potentially not require the physician to be consulted with a routine follow-up examination, we can't take dollars and use those to pay a nurse. On the other hand, if physicians were part of a care team and paid for a salary, paid by a salary, perhaps the fungibility of dollars used to provide income to healthcare professionals could be better distributed, and the system might be more sustainable on that basis. You then get into the argument of, well, if physicians aren't paid fee for service, they won't provide the same volume of care. In my mind, as a surgeon who has worked on fee for service all my clinical life, and prior to that as a general practitioner, I have never, ever been driven by the fee-for-service system to perform more care. That's just not something that fits into the mindset of most practitioners in terms of the day-to-day incentives that drive our practice. The other thing, I think, that may change this argument to provide us with more opportunities for salaried physicians is the desire of people graduating from our medical schools today. Most people graduating from medical school don't necessarily want to set up their own small business, and that's what a fee-for-service practitioner is. The tendency is to want to move into a family health team, into some sort of rostered care provision, where they're essentially salaried. They can vary their income based on who they're seeing and what size of practice they're in, etc. But there's a certainty of income, and most importantly, certainty of infrastructure. And that certainty of infrastructure, as opposed to setting up a small business, I believe is something that's going to make doctors of the future more eager to work for a hospital where they've got a predictable income. The other thing, of course, is that physicians today are very worried about security of income after they finish working. And having access to the benefit packages provided by Ontario hospitals, including pensionable income, I think is something that's going to make a salary look pretty attractive. Finally, we know how to measure physician performance in the Ontario hospital system pretty well. We know how to think through workload. We know the variable sorts of activities we want our physicians to work on, whether it be direct patient care, coordinating patient care, or enhancing quality. And we can think of ways to schedule work time, work life. Scheduling around physicians' time spent at work is something that we can be very sophisticated in understanding, negotiating, and making that part of a physician's salaried approach. So I think you can hear from the tone of my remarks that I don't have any strong bias one way or another. I've worked as a fee-for-service doctor. I've seen the advantages of that. I think in the future we're going to see more and more physicians working in a more structured, salaried environment. Great. Thanks for asking.